Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we hear from Mark Monaghan, WA Country Health Services Emergency Department Clinical Lead and the Director of Medical Services in the Southwest, about the Green Hospital Initiative. This podcast was presented at Rural Health West's Rural Emergency Forum in October 2019.
All right, so look, thanks for coming. I'm going to talk about Green Hospital Initiative, and this is a subject that's really close to my heart. I think that it's become a really complex discussion because it's so politicised and climate change is so politicised. But if we sort of pare it back from that, it just makes sense to do what we can to limit our environmental impact, climate change aside, politics aside. And so what I'm going to talk about is a general sort of health approach to that, and particularly what we're doing in the Southwest, because I think it's just an interesting thing to think about in terms of your own health services. Australia's probably quite behind on this, and this is these references are to the NHS, and they've just released a campaign to tackle the climate health emergency, which they've declared. And I've got two or three slides which are direct quotes from their sort of media release on this. They've been doing a lot of work for certainly over the last decade in trying to reduce the environmental impact of their hospitals. Now they make this is the first part of their release. The cause of air pollution and climate change are often the same. So for a greener NHS campaign, we'll help address both. The health and care system in England is responsible for an estimated 4 to 5% of the country's carbon footprint. For us, it's 7%. And a recent study by King's College London looking at 9 English cities demonstrated high pollution days there are 673 additional out-of-hospital cardiac arrests and hospital admissions for stroke and asthma, with spikes in ambulance 999 call-outs. So that's just, standard life. It's not a big event, it's not a big bushfire, it's nothing like that. And I'm going to talk more about that in reference to our system in a tick. The changing climate is leading to a more frequent heat waves and extreme weather events, such as flooding. They get a lot of deaths in their heat waves. And in previous talks I've done for Rural Health West, like at last year's forum, there were heat waves in Russia that killed 50,000 people and so on. So they are catastrophic for those countries that aren't used to heat, but similar events occur in our climate and our community. So they're going to basically go to a net zero emissions for their NHS program, and they've set up a panel to do that. And one of the chaps that's leading that is an Australian doctor. And he's coming out later this year, and I think towards the middle of the year, to talk to our health services about what they're doing. They are reporting on their greenhouse gas emissions. Our health service doesn't do that. It's a complex thing to report on, to working out what your carbon footprint is and what you're doing, but they're making that effort to do that. And as I say, they've done a lot of work around photovoltaics on their hospitals, where they source their food, and we're going to go and talk about some of the other things that you can do to make an easy difference that they're leading the way on. They're also much better on their vehicle emissions than what we are. And they have more of a reason to do it, admittedly. They have really complex, densely populated urban environments. But, I came up from Margaret River yesterday to talk today, and I decided to ride the motorbike up, and I thought I might come through the Southwest Highway because it's prettier. And I hit Armidale, and it was hot and it was muggy and there were cars everywhere, there was concrete. That urban heat sink that we talk about as that concept is so confronting when you live out in the country now. And you don't notice it when you're living in the city so much. You just think it's normal and you think it's hot. I was staying at my father's place nearby here last night, and I was awake during the night because the place didn't cool down. There's concrete everywhere. And in the country, it is cool until it's 5 o'clock just because we have trees everywhere. So I was confronted by this sort of Armageddon thing riding through Armidale with all this traffic, and there was air pollution everywhere, and it was stinking hot, and there was concrete, and I thought, what are we doing here? It's just really, really, the contrast is always confronting, isn't it? But it really brought it home to me. Basically, the NHS is looking at a zero output, zero emissions, including all the transport that they use for the hospital, and it's looking at their consumables, their pharmaceuticals, and their energy utilisation and using renewable energy. So really wonderful. Catherine Henderson, the President of the Royal College of Emergency Medicine, talked again about this and the air pollution and the adverse events, and we know they have a huge impact on ED presentations. And so the Royal College of Emergency Medicine has declared a climate emergency. Now that, in a way, we hear that and we go, oh yeah, well, what does that mean? But they're putting stuff behind that in terms of doing some work to improve their activities and their systems, and I think that's wonderful. Here, we know we're a hot country, but we know we are getting a longer duration heat period. We're getting more frequent and more extreme weather events, particularly heat events, and it's our vulnerable members of the community anywhere across the world that are the ones affected. It's the elderly, it's the young, it's the people that are in low socioeconomic conditions who can't either access better air conditioning, or their power goes off, or they're socially isolated, mental health patients. It's all our most vulnerable people that we should be doing things for. These are the people that are at greatest risk. These are the people that die. Every extreme heat event, our increase in mortality, just from all-cause mortality, older people, complex medical problems dying, occurs. And so we get more cardiac arrests. We get more people dying because of the medications they're on, and their cardiac disease and their respiratory disease. In 2009 and 2014 in the eastern states, 64% and 60% respective increase in ED patients requiring immediate resuscitation during those heatwave periods. And that was the period where they had, I think it was Black Saturday, and they had, I've done this talk before, and I didn't bring it into this talk because I want to talk about other things, but they had X number of deaths, 100 and something, 170 or 200 and something deaths. But they had more deaths just from all-cause mortality, just from people having cardiac arrest, and that's not seen. It's disguised, and we get appropriately really upset about people dying in fires, but people just die in heat waves, and we don't even notice it. It's just part of our gig, and we just get elderly, complex people coming to rest. And now that's going to only occur more and more frequently. It's going to impact on our health services, but most importantly, it brings in a whole lot of considerations about early warning systems and how we protect our communities, and what role GPs have in that, in terms of identifying the patients that are going to be at risk, that they're on their anticholinergics or their vasodilators, and making sure that there is a system in place, that they do a pre-summer check, and that the family's aware and what to look out for. And indeed, in smaller communities, a system where people are checked on during extreme weather events, and that may be through the postal service, or it may be through a community service or some local government sort of mechanism, or through the GP practice, and knowing the patients that you've got there that are at risk. So we need to think about those things, how we protect our people. And clearly, as we've seen just in the last couple of months, bushfires, smoke effects on respiratory disease, thunderstorm asthma in Victoria, this is all going to become more and more relevant. And it's real now. 26 and 27% increase in emergency presentations. During thunderstorm asthma, there was something like 3,000 extra presentations of the Victorian EDs during one day. How do you cope with that as a service? 25 and 16% increase in urgent presentations, so ATS 1 and 2, and an increase in overall death ranging up to 25% increase in deaths. Really significant numbers, and for anything else we'd be sort of horrified, but for this, just for some reason it seems to slip under the radar. So what are we doing about it? Well, there's a number of levels that things are happening, which is really encouraging, and I want to go through them. For a start, the Minister for Health has been a really active driver of this. There is something just personally, he seems to be really committed to this work, and he is encouraging the health services to really respond to this and to do work in this space. So he's, as a key recommendation of the Climate Sustainability Forum, which he attended, and a key priority of the Sustainable Health Review, the Climate Health Inquiry was initiated, which has been conducted by Professor Taran Weramanthi, and he's a wonderful fellow, for those of you who know him, and very clever. That's been running since March 2019, will finish in a couple of months, and then they'll have a report out a couple of months after that. And there we can expect probably 10 recommendations around how the health sector can change their approach to climate change. And remember, every time you talk about this, is about mitigation as well as adaptation. So what can we do to lower our emissions and our impact on the environment? But also, what do we have to do to get ready for, and to adapt to what is going to be an increasing health presentations as a consequence? The Minister has also written to the CEs of the health services, encouraging them to join the Global Green and Healthy Hospital Network, which WACHS has done. Southwest Coastal, which is where I'm the Director of Medical Services, we joined in 2018, and WACHS joined in 2019. And this organisation is an organisation that now has about 1,000 registered members across the globe, accounting for about 36,000 health services across the globe. And it really is a platform to share experience and knowledge and provide support to get you to do this kind of work. So they offer us guiding documents. They've got about 10 pillars, which I'll get to in a sec, but they offer guiding documents on how you might approach issues in health services. And some of these are from Central Africa, and so they've got a completely different environment to us, but many of them from the UK, from Europe, from the eastern states, places that have got equivalent kind of medical services, and they often exemplars on you. If you do this, then this is how we did that. This is the outcome we got, and so on. So they're interactive platforms to discuss challenges. I can contact them with a issue we might have, and somebody will come back. Oh yeah, we did that. There are webinars. When I first joined up, a guy had a meeting with a chap via VC in California who was involved in this, and he talked me through a lot of the issues, and it was tremendously helpful. They have a really good data centre to help calculate your current carbon footprint and help track progress, and so it's a very worthwhile sort of organisation and well organised. And these are the pillars. They look at all of these things in determining how a health service can change their environmental impact. Leadership, and we'll talk about some of these in a tick, but leadership I think we have now. We have that from the Health Minister, we have our CEs involved. Our CE, Jeff Moffat, is very engaged in this, and I've had multiple chats with him on this. But interestingly, at an organisational level, we're still evolving. It's still considered a little bit, I think, and it's still considered a little bit left of priorities. It's a little bit on the side of them. Our priorities are patients, but this is the number one global public health issue now, and will become more so. So actually it is central to what we do, because if we're looking at our patients and their best outcomes, we need to consider this as part of that. So these pillars: chemicals, waste, energy, transport, food, water, pharmaceuticals, buildings and purchasing. I'm just going to go through a little bit of, this is not comprehensive at all, but these are sort of things we're thinking about, and then I'm going to talk about what we're doing locally. So it's what chemicals you're using, what cleaning products you're using. Are you using mercury, and how do you deal with the mercury after you use it? PVC and phthalates, they're concerned about the impact on people of using them, and they're in a lot of our plastics to make them flexible. Are they the right chemicals to be used? Are there better alternatives? So you're always looking for substitutes that have less of an environmental impact. So that's one of the principles. Waste, obviously we've all seen sort of War on Waste and things on ABC, and single-use plastic. I don't know, we all suture people up. We all chuck our suture tools away straight away. They go into a bin. Ours in our region don't get recycled. So we've got a whole lot of stainless steel going in every day that doesn't get recycled. PVC in oxygen mask tubing and so on. Copper wiring, so in all our ECG lines and things, there's copper wiring inside that can be sold off, and you can get money for your organisation for doing that, and it can be recycled. And there's obviously a lot of organic matter, not obviously dead people, but food and things that aren't used that could go into. Now things like this last one, they're not going to change our gig on our carbon footprint to a large degree, but they do go to landfill. And there are things like this that are important in terms of engagement. I'm going to talk about that in a sec. Energy utilisation, so reduction strategies, reducing temperature control for areas of the hospital not used at night, so you don't have the air conditioning bill. Lights, photovoltaic systems, obviously, and that's something we'll certainly be looking at in what the work we're doing. Getting the organisation to commit to a renewable energy target and an emissions target. Now, health hasn't got one at the moment, but we've just seen that NHS has got one. My expectation is that over the next few years, we're going to see Australia follow, certainly Australia follow suit, certainly West Australia follow suit. I think part of having those chaps out from the UK is to talk about how we might get to with that. It's a big step to do it. There's a lot of complexities around that, also including Treasury and our relationship with the energy providers and so on. So there's a lot of work to do to get there. But there's an opportunity, and then there are some things we can fix, some things we won't be able to fix, but then do we generate income from smarter things like saving on our energy bills and put that into reforestation in our rural communities and help the rural community and offset the things that we can't actually control otherwise. So there's real good opportunity there, not to mention engagement with the community with that. Transport. We all have fleets of vehicles in all our hospitals. Why aren't they hybrid? Why aren't they electric? Why doesn't each hospital have a charging port so that when I drive from Busselton to Bunbury, I charge my vehicle up while I'm in the meeting and then bring it back? Those sort of things.
Why do the administration have to always travel to Bunbury instead of doing it by VC?
We do a lot of VC, and Andrew's one of our EDMSs for WACHS, and he's on the IT side of things, and he will probably tell you later on. But VC for us, particularly around ETS, is incredible. I mean, it's growing all the time. I reckon probably, quite honestly, 3/4 of my meetings, and certainly distant meetings, probably 95% in our VC.
It's something that we're only now starting to measure properly. It's the savings in not having to move people, which, you know, the use of advanced video conferencing for patients has got a double-edged sword, because we also know that we do sometimes move people that we wouldn't have moved. But it does, and video conferencing is a very carbon efficient way of doing things.
And remarkably good. I've done. Do you do ETS shifts at all? No. So I've done some, and they are. It is almost like being in the room with the patient. I mean, it's so good. The technology is so good, and you know, we have a lot of mental health sort of reviews now and things. I've dealt with palliative patients who are dying through ETS, you know, that have come into an ED and things. I mean, the technology's astounding. So
it's strange. We had a kind of I work for the Rural Clinical School, and we had a similar kind of like debate about maybe we should shrink the number of actual meetings we have for this sort of reason. And the team kind of did split, and there was a sense of, yes, everything you said, it's very efficient, but I think we haven't. There's also that kind of tribal aspect of catching up with people, having coffee. You know what I mean? There is the other side as well, that sometimes a physical meeting has a lot of benefits that you just can't quite capture without a VC. You know, that's the other side of the coin.
And I think it's really true. And it's like we talked about the last chat about the human element. I mean, there is a human element about being face to face with somebody and having a yarn, and there are nuances you may not quite get. You know, the vibe of the room, that kind of thing, and just spending a bit of time before and afterwards that are important. They just probably could be a lot less frequent. They're already a lot less frequent than what they were, and I think that's a positive thing. So food, I mean, there's interesting setups in the US in some places where they create a co-op of the local farmers and they supply the organisation. So you're not only getting fresh produce that's got low food mile, but again, you're engaging with your community and supporting them because you're paying them to provide. And you've just got to be a bit flexible with your menu for that week, depending on what's in season. But you know, kind of, again, these aren't going to change the world, but they're very sweet things to do, and they're mutually beneficial across the community. And the more we can do to engage in our community with our health services, the better we are. Really, I think on multiple levels.
There's a lot about messaging.
Yes.
And that isn't there, in terms of the fact that if you look at in small towns particularly, the medical service, the school, the police, and to a lesser extent the banks and all those, because unfortunately, as you know, things are closing down a little bit. But I think there's a responsibility on us to message to the community that we are invested in that.
Absolutely. And I think also, if you look at any rural community, there'll be quite a split in people that actually, you know, that think that climate change is important, others that actually just don't. And that's all right. But so instead you couch it in this, this is still a public health, an enormous public health issue, the public health issue. That's our job. So we're going to work on this. And we're also doing things that engage. We're doing it. We're doctors, we're nurses, we're health professionals, we're caring for people. This is why we're doing this. But also we're doing stuff that's actually going to help our relationship with the community. To me, that's the way that you have, and that's how I'm going to try and manage it in the southwest. Water, so water recycling systems. We have an enormous roof span on most of our hospitals. We don't collect any water on any site that I know of and reuse it. Pharmaceuticals, anaesthetic gases are amazing. So this is an incredibly busy slide, only because I won't go into any depth, but I watched this remarkable podcast from an anaesthetist in the UK about inhalational versus total intravenous anaesthesia. And SIVO, ISO and desflurane, in order, have huge emissions from 1 250ml bottles. So 886 kilograms of CO2 emission equivalent from desflurane. That's because they sit in the environment, in the atmosphere, for varying periods of time. In the case of DES, it's 14 years on average, and they do the same thing that CO2 does in terms of absorbing heat and holding on to heat. So they measure things in terms of CO2 equivalent. So nitrous, 3.4 kilograms cylinder, 1,054 kilograms of CO2 equivalent, and it lasts in the environment in the atmosphere for 110 years. And then there's low flow versus high flow techniques. Now, I'm not an anaesthetist, but as I understand it, you can use these volatile agents either on a high flow system where a lot of it pours out the extractor, or a low flow system and it recycles better and you use less. And going to those low flow systems and reducing the amount you need, if you're not going to go to total intravenous, is a positive step. This for them is 5% of their organisational carbon footprint alone, just in anaesthetic gases. Now that is about shifting people's behaviour, and that's about engaging with them and pointing out the issue and bringing them along with you, rather than just insisting suddenly we're going to all use TIVA and you better all learn how to do it. But this is actually a big deal. And how many of us knew that sort of 5 years ago? So, and again, a lot of this, there's really great UK work being done about this. So this I think, to me, that's quite exciting and interesting, and that's, again, going to be part of what we're doing. Buildings, energy efficiency, solar passive design in new works. We still build new hospitals, incorporating that into them, but certainly doing what we can to retrofit our current buildings that need it. We've got a couple of very old hospital sites in the southwest, and it'd be lovely to see what we can do to improve those. And purchasing, so essential environmental focus on all new contracts and purchases. So does it, considering that as part of the element rather than does it do its job, what's its cost? Having this sort of other element into this is a really important thing. Waste, and for some reason I've dropped the waste slide, but waste is a big thing, and WACHS has got a fairly comprehensive waste strategy, but strangely enough, the metals are not part of it, because we deal with a service provider that doesn't recycle metals. So again, looking at your contracts is going to be an important part of it. So you can see how complex this is once you get into it. Anyway, I just want to finally sort of talk about the Southwest Coastal Plan. So we have Southwest is a fortunate place in many, many ways, and it's attractive and it's comfortable, and there's increasingly big population. People go down there obviously because it's beautiful and there's a lovely coastline, and so it's seen for its natural beauty. So it seems a really sensible place to try this. So what we are doing is we have 3 hospitals down the southwest coast: Busselton, Margaret River and Augusta, in decreasing size. And we are going, because we have an ops manager and me and a lot of staff that are common to them all, we have a shared sort of symbiotic relationship. So we have created, we're going to create a green hospital template. So we're not just going to look at anaesthetic gases or recycling food or our waste. We're going to look at all of those pillars and run them in parallel, a reform process around them over the next year. And we've just appointed a project officer who's a wonderful sort of clever, vibrant woman who knows health very well, who is going to full-time for a year. So Jeff Moffat's sort of given us the opportunity to full-time for a year to run a initial carbon footprint assessment on our 3 sites, and then look at all those pillars and run them simultaneously and work out what we can do to improve our performance in each of them. And then come out at the end with two things. One is and during that time also, we are going to run smaller sub-projects. So, because the staff are hugely engaged in this, and when I've emailed them and asked who's interested in joining in, I had this flood of emails that still comes. So we need to harness that energy. So Rachel Martin, who's our project officer, is going to coordinate the sub-programs. We've got a project control group, which I chair, and we had our first meeting last week. Rachel starts next week. And we are going to oversee the smaller projects, because you don't want to do this wrong. You don't want to start changing over something like the IV sets and find you have an infection control challenge. So we have an infection control person in there, and they're going to guide us on that. So, and people can't go rogue. They're going to, whatever they're doing, we're keeping an eye on, so that nothing negative comes from it. But we are going to create. Our plan is at the end of the year to create a template. And if we need more time, then we'll do it. But a template that we can then give to other health services and say, we've looked at all of this. This is how you do this, so that rather than starting from scratch, they can slot it into their environment and their service, and it makes it much easier to do it. And our hope is that will replicate across sites. And then my hope, and we'll create business cases for what we need, because we know that in the short to mid-term range, you can save a lot of money if you start using renewable energy for things, or save money on how, recycling your waste rather than landfilling it. And then using that money to say, well, let's make a business case to offset the rest of the stuff we can't fix. So that's what we plan to do over the next year. And then we'll create, hopefully, initially business cases for ourselves to try and get those things put in place that we want, like whether it be photovoltaics or big rain tanks or changing equipment that might be more expensive but is better environmentally and so on. So there'll be a lot of potential business cases that come out of that. We'll then put them back to WACHS and say, does this make sense to you, and would you support that? So, but on the whole, overall, I just want to create a template that makes it easy for other sites to do this thing. And then if we do that across the board, and then if we can export that to other states and so on, brilliant. We've done something worthwhile. And although, the overall effect on emissions will be small, the message is significant. And if we're engaging our community in it, there'll be a flow-on effect to people in terms of them thinking that way as well. And if we keep talking about this being a public health, huge public health issue, public health emergency, whatever it may be, talk about it in a sensible way, they'll understand we're doing it for the right reasons and not for any politicised reasons. And the question's really for us as an organisation, can we aim for net zero emissions? And I really hope we can, and I hope that over the next couple of years we start seeing that as health services. So anyway, that's what we're doing. I think for me it's incredibly exciting. So give it some thought, and hopefully we'll get something out sensible to everybody else when we get to the end of our next year. Anyway, that's it.
Thank you, Mark. That was an excellent presentation. I'm quite excited to hear of all the interest and development that's obviously going into this. When I started, of course, we had 2 large autoclaves in the hospital, and we recycled and cleaned everything, even reused bandages. Now, of course, sadly, everything's disposable. We, as you mentioned, go and do a suturing. Some of the equipment isn't used at all, but all of it goes into waste, which I find absolutely appalling. You didn't talk specifically about that, but is there anything in that development? I appreciate there's infection control issues, but the amount of waste is just appalling.
Piggyback something onto that.
Of course.
Patients regularly complain to me and are shocked by it. So I think even though
As
we're
our
doing
staff,
all this, patients regularly say to me, because I work in Northern ED, and they say, well, you're throwing that out, and the blankets get thrown out, and the pillows get thrown out. So regularly, I think we are seen as very bad examples, even though all this good stuff's happening. So maybe for what it's worth, discreetly describe things, because I don't want to publicly be seen to be showing a bad example. So I totally agree. But it's just patients regularly are shocked at what we do.
So
And I can understand why.
I noticed that because the equipment, the stainless steel equipment, doesn't seem to be as good. So the scissors, they actually don't work as well. And also with their disposables, the plastic sheets, which I'm horrified by. So I'm always trying to get them to sit in a chair so I don't have to change the sheet on the bed. So I really wanted, curious in that question, and also whether with the sheets in the UK, if they're using plastic sheets or if they're doing something a little bit different.
Yes, I don't know the answer to the UK, but two of the sub-projects that we're going to start straight away, because what I was trying to say before is that, you know, when you're doing big reform, it's smart to run smaller things to keep people engaged while you're doing it. And so one of them is stainless steel recycling on equipment. And as I said, we don't have our contractor doesn't, for the Southwest, I'm sure there are different contractors around the state, but our contractor doesn't recycle metal, so we're going to look at whether we can find another contractor to do that bit, and there'll be discussions around that, and that's obviously complex, but there'll be a way of doing that. So one group's going to, somebody's already charged with starting to look at that, and they'll report back to our project control group. The other one is more general thing around waste, including the copper wiring and the PVC that one of our other sites has got $5,000 grant to do from the recent sort of, there was a push through WACHS, you may not have seen it, push through WACHS to look for innovative ideas, and they were offered money to support them. So that is another thing. So we're looking at both those. We're looking at waste as one of our first two things because, as you say, that's the thing that's so confronting on a day-to-day basis, both for our staff and for our patients.
And the other thing about those instruments is that sometimes you've got to open a second pack because the first pack was so crappy. You know, they just
Exactly.
don't. They really are poor quality.
Yeah, and even like I used to find laryngeal blades, the disposable ones, were not as good as the real thing. So you compromise quality, don't you?
Well, we now do use new blood pressure cuffs for every patient that comes through the door. I mean, I have no idea why, but you know, the trick is infection control. They do a wonderful job, but they're by nature and have to be very conservative, and hence we've got that new IV pack that is enormous. And so there'll be some tough discussions during that about demonstrating benefit from having all that plastic there and why we actually do that, because we always have, what we're going to do as organisations and as humans is always go to less and less risk. And we have to balance that with the impact of going to less and less risk all the time, don't we? And so I think that's, you're looking like you want to say something about that.
Just the example of needle stick prevention. Since that universally came into devices, it means that nearly every single device with a sharp point has got another piece of plastic on it.
Yes.
Yeah.
And they don't work as good.
And it's I know what I do, but most people don't like them and they prefer the old-fashioned ones.
So a lot of this is going to be about being good at having negotiating, I think, and really teasing out what provides benefit and important benefit and which could probably be left aside because in fact there's a negative impact outside that they're not considering and talking about that. And I gather at the next big national OSH conference that they have, environmental impact of what they're doing is part, environmental impact is part one of the talks on it. So that's good. So it's, things are slowly shifting anyway. I hope we get something really good out of this. We're going to try really hard to do it. Thanks for coming, not going to the other talks. All right, all the best. Cheers.